Thanks very much, Pulling, and thanks to the organisers for the invitation to address advanced HIV disease. And I really want to just focus on what the challenges that we face in 2025 around advanced HIV disease. So to start off with, just to say that the WHO defines advanced HIV disease in adults and adolescents as a CD4 of less than 200 or stage 3 or 4 clinical disease. But from the outset, to say one of our big challenges in this field is that CD4 count testing is becoming far more difficult to obtain. Governments have deprioritized it. Companies are terminating platform manufacture. There are obviously rapid tests in the pipeline, but the performance of those is suboptimal, particularly with respect to specificity. And this is going to negatively impact clinical care and also our ability for surveillance of advanced HIV disease. And just to say that clinical staging is a poor surrogate because patients can be completely well and yet have a low CD4 count and be at risk of subsequent opportunistic infections. Just the big picture globally in terms of HIV deaths, you can see it. HIV deaths peaked in 2005. There's been an important decline due to ART scale-up, but there's really been a plateau at around 600,000 over the last few years, and that's really driven by ongoing prevalence of advanced HIV disease and the incidence of opportunistic infections and TB as a consequence. And so our best estimate in Africa of advanced HIV disease comes from this a study led by the WHO, the FIA studies done in 12 countries across sub-Saharan Africa, which involved household surveys, testing people for HIV and then looking at CD4 counts. And the pool prevalence of a CD4 count below 200 across these 12 countries was 10%. And taking that and extending it across Africa gives us an estimate of about 2 million people living with advanced HIV disease in sub-Saharan Africa currently. If one looks at it at a hospital level, this is just data from Cape Town looking at 3 hospitals and looking at the percentage of people admitted to hospital who are are living with HIV and comparing 2013 to 2022. And you can see there was little change over that 9-year period, despite a scale-up of ART in communities. And that really speaks to the fact that there's ongoing advanced HIV disease affecting people, leading to hospitalization and a high burden of morbidity and mortality due to the ongoing issues. And we're going to speak to what some of the factors resulting in that are. In terms of outcomes, this is from 2 global meta-analyses led by Nathan Ford. Overall, among adults admitted to hospital with advanced HIV disease, around 20% of them die in hospital. About 15% died during the next year, and about 20% required readmission within a year. So about 1/3 of people admitted to hospital with advanced HIV disease will die. And in some settings, obviously, that's much higher where there's poor access to diagnostics and treatments. The major causes of hospitalization and death in advanced HIV disease from a meta-analysis that was published this year between 2014 and 2023 in Africa. Major causes of hospitalization were TB and bacterial infections, accounting for over half of hospitalizations. And you can see that doesn't sum up to 100% because many of the diagnoses were simply labeled as gastrointestinal infections or neurological infections. This just refers to where there was an etiological diagnosis. And from autopsy studies, meta-analysis of autopsy studies, we know that TB, once you look hard for it at autopsy, accounts for over 40% of deaths among people living with HIV in Africa. And in about half of those cases, it's TB that's not being diagnosed before the time of death. So wouldn't be captured as a cause of hospitalization because it's missed TB. And often that's disseminated TB. So I've just really sketched out that the data from the previous slide and from other studies to kind of give you a big picture of what the causes driving death in people with advanced HIV disease are. And you can see the 2 big causes of death are really tuberculosis and severe bacterial infections. But just to say that one of the big problems is we know that from research studies where there's intensive investigation of patients. But in routine clinical services, because of lack of access to diagnostics and the limitations of the diagnostics we have. In many settings, the majority of deaths are caused by unknown causes, and the cause of death, the etiological factors leading to the deaths in terms of what pathogens are involved are not ascertained in the clinical service, and that really speaks to the need for improved diagnostics and greater access to diagnostics, a programmatic issue that underpins the whole AHD field. And I'll come back to that at the end. So I just want to now pick up on 4 of the major drivers of hospitalization and mortality in advanced HIV disease. Firstly, TB. To firstly say that the incidence of TB is obviously increased at all CD4 counts in people with HIV, but with a CD4 count of less than 200, the risk goes up 25-fold. And it's not just the risk of TB itself that goes up at a low CD4 count. There's more rapid clinical progression. We encounter more commonly severe forms of extrapulmonary TB like disseminated TB and meningitis. There are diagnostic challenges at low CD4 counts, higher mortality, and more frequent complications. And just to illustrate some of these points, a meta-analysis showed that on average, about 45% of people with HIV admitted to hospital with TB have a blood culture that's positive for TB, suggesting dissemination. In our studies in Cape Town, among people with HIV in hospital with TB, only about 40 to 80% can produce a sputum sample, limiting our ability to diagnose TB rapidly. And then there's high mortality between 20 and 35% of people with HIV admitted to hospital and started on TB treatment in hospital. Obviously, there have been diagnostic advances with the Expert and the Expert Ultra and other PCR platforms, and we have the urine lamb now. But what has been shown that combining a sputum Expert and a urine lamb only results in a diagnosis in about 70% of people with TB with HIV in hospital. And the other third, we need extrapulmonary testing. Sometimes we need empiric diagnoses, and we need new approaches and better diagnostics for TB to shorten the time to starting TB treatment and improve outcomes. And then finally, to say that there are a number of treatment trials going on currently to try and reduce that mortality associated with HIV TB in hospital. Our own study, the Newstrat TB trial in Cape Town, the Dartura trial, and the Atlas trial, but I won't expand further on them in this talk. Then in terms of cryptococcal meningitis, it's estimated that cryptococcal meningitis accounts for around 20% of global HIV mortality. The WHO currently recommends induction therapy with a single high dose of liposomal amphotericin B, followed by 2 weeks of the oral drugs fluconazole and flucytosine. So that is the recommended regimen, the preferred regimen by the WHO. But realizing that liposomal amphotericin B isn't widely available, the alternative induction is 1 week of amphotericin B plus flucytosine, which has greater side effects, but similar mortality at 10 weeks of around 25%. So in Africa, even in the best settings, in a clinical trial setting, still 1/4 of people will die with cryptococcal meningitis. And obviously, in routine care settings, there's not access to many of those drugs, and there's not the same standard of care provided as one would get in a clinical trial, and so mortality can often exceed 50% from cryptococcal meningitis. In terms of pneumocystis pneumonia, a meta-analysis of studies done in Africa showed that about 22% of people investigated for respiratory conditions in a hospital in Africa have PCP, with a case fatality rate of around 20% as well. What's underappreciated is that pulmonary fibrosis complicates severe cases of PCP, as shown in the histology slides on the right-hand side. And the mortality can be substantially higher. From our hospital in Cape Town, you can see that 90-day mortality was close to 40%. And then another major cause of mortality in people with advanced HIV disease is severe bacterial infections, where the etiology is ascertained. The common pathogens are pneumococcus, salmonella, and other gram-negative bacteria. Obviously, in many settings, there's limited culture capacity, and so the etiological diagnosis of the bacterial infection is not made. And often clinicians need to start empiric antibiotics, not knowing the susceptibility profiles in their setting and doing it blindly. And that's a major limitation, is the diagnostics for bacterial infections and having susceptibility patterns. Obviously, we use cotrimoxazole in our program for primary prophylaxis. One of the problems is it has limited coverage for those common bacterial pathogens. And there's been interest in expanding the bacterial primary prophylaxis. And one consideration has been the use of azithromycin, which has coverage of, for instance, pneumococcus and salmonella. And the reality trial, which involved a package of care that was conducted in Africa, and part of the package of care included 5 days of azithromycin, showed that that package of care significantly reduced 24-week mortality from 12% to around 9%. But azithromycin was not adopted by the WHO guidelines for inclusion in the package of care because it was felt that there wasn't sufficient independent evidence. And we're addressing that currently in the REVIVE trial that's looking at primary prophylaxis with azithromycin in people with advanced HIV disease and a CD4 count of less than 100. Asking the question whether adding azithromycin, 28-day course of azithromycin, for the first 28 days of starting ART or restarting ART reduces 6-month mortality. And this is a placebo-controlled trial being done in 14 countries across Africa and plan to enroll 8,000 participants for sufficient statistical power to show a 20% reduction in mortality. And at the moment, we're recruiting in 9 countries currently and have recruited just on 2,400 patients across those countries of the planned 8,000 participants and hope to have results by early 2028. So what are the key drivers of advanced HIV disease? Firstly, late entry into care. Over 30% of people still start ART with a CD4 count of less than 200. And a study from Uganda presented at CROI earlier this year showed that many people are living with advanced HIV disease, with HIV in the community, not having started ART. The disengagement from care that was addressed in a session this morning. In the Western Cape province of South Africa, it's been shown that of the 500,000 people living with HIV, at any given point in time, a quarter of them are people who have previously been on ART and are currently disengaged from care. And obviously, those people with low CD4 counts in that group have high risk of developing opportunistic infections. And of course, the current funding crisis threatens retention in care even more and may mean some patients having to stop or interrupt ART against their will. And this just is from a recent publication from the IDEA cohort showing in the top panel, the CD4 testing in some regions of Africa. This has declined to less than 20% of people having a CD4 count on entry into care. And then in the bottom panel, the proportion of people with a CD4 count of less than 200 on starting ART. And you can see this nice decline through the 2010s, but then it plateaus at around 30% of people starting ART with a CD4 count of less than 200. And there are many reasons for disengagement. This was covered in the earlier session. But what I want to touch on is what's underappreciated is how quickly the CD4 count drops after stopping ART. And this is particularly an issue in patients who start ART with a very low CD4 count. And you can see that, that in the SMART study, where there was a planned interruption, the CD4 count dropped by over 200 in 4 months after stopping ART, and it approximated the baseline CD4 count within 3 to 6 months. Another study that was presented at CROI earlier this year with analytical treatment interruptions, what you see is that 95% of people have viral rebound within 12 weeks of stopping ART. So among those people interrupting ART, if their CD4 nadir was very low, we can expect that their virus will rebound within a few weeks, and that their CD4 count will drop back down to that nadir within a few weeks of, within 3 to 6 months of stopping ART. And of course, then that puts patients at risk of advanced HIV disease. What I want to refer to next is the WHO package of care that was first recommended in 2017, has been incorporated in subsequent iterations of the WHO consolidated guidelines, and this includes a package of care for people with advanced HIV disease, which includes screening and diagnostics, TB screening, use of sputum PCR tests to diagnose TB, urine LAM, both for diagnostics as well as screening of people with advanced HIV disease, cryptococcal antigen screening, prophylaxis with cotrimoxazole, TB preventive therapy, and fluconazole for those people who are cryptococcal antigen positive, ART initiation unless people have meningitis, and adherence support for people that's adapted for people with advanced HIV disease. And one of the issues is this is a package of care which is underpinned by good evidence of improved outcomes with implementation for each of these components, but there's been patchy implementation across Africa. And this is even more threatened by the current funding issues that we're facing. So just to pick up on some of the aspects of the package of care, the urine LAM assay that works particularly well in patients with the lowest CD4 counts, so patients with advanced HIV disease. There are 2 trials done in Southern Africa that showed including the LAM assay in the diagnostic workup of people with HIV in hospital reduces mortality. So this is a diagnostic test with a mortality benefit and forms part of the package of care. Cryptococcal antigen screening. Cryptococcal antigen is positive in the blood for up to 3 months before patients develop meningitis. About 7% of people with CD4 counts of less than 100 starting ART have cryptococcal antigen in the blood. There's a simple test to test for it, and the REMSTART study showed that including cryptococcal antigen screening and fluconazole prophylaxis for those patients who were positive reduced mortality by around 30%. But obviously there are operational challenges with introducing this within care. Cotrimoxazole prophylaxis has been around for 2 or 3 decades. The evidence for this is about a 60% reduction in mortality. And finally, TB preventive therapy. The WHO recommends isoniazid or 3 months of rifapentine plus isoniazid weekly, or a 3-month regimen of daily isoniazid plus rifampicin. And there's good evidence for INH preventive therapy, reducing mortality in the Temprano study and reducing TB in both these studies. And for 3HP, which is weekly INH plus rifapentine for 3 months, shown to be non-inferior to longer courses of INH, and the Dolphin 2 study showed that it can be used with dolutegravir. And then just to finally say what I've spoken about is the advanced HIV disease package for people in outpatient settings. This policy brief from the WHO also speaks to the care of people in hospital. And I don't have time to go through this today, but just to refer you to this document. So in conclusion then, in terms of preventing deaths due to advanced HIV disease, what I've shown you is the 2 major drivers of advanced HIV disease are delayed ART initiation and ART interruptions. The funding cuts that we're facing are going to potentially worsen that. And the high mortality associated with TB and opportunistic infections in patients with advanced HIV disease is something that we face in our hospitals. Really, we need to work upstream by ensuring patients are started on ART early, that we improve ART retention and reduce interruptions in care, and prevent and diagnose opportunistic infections early. I think the package of care that I've shown you is more important than ever. And the one infection that we've really got to focus on is screening for TB and avoiding delays to starting appropriate TB treatment, because that is the major driver of mortality. And what I haven't referred to, but has been picked up in a number of studies, is the need to improve strategies for linkage to care after hospital discharge, because that's often where we lose patients with advanced HIV disease. So thank you very much for your attention.
Thank you.